Yeah, so basically I'm going to talk about dizziness and syncope, but mainly concentrate on syncopal attacks because they're the most dangerous and most significant. So, definition of dizziness is a very sort of vague term and can be used to describe a range of sensation from feeling faint, woozy, weak, unsteady, lightheaded. So it means different things to different people. But there are four main types. One is the first one is vertigo, which is sensation of movement. Either the patient or the surrounding feels that it is spinning. There's this equilibrium, the second type, which is sensation of balance simply. The brief syncope, which is the sensation of impending fainting. And then syncope, which is a transient loss of consciousness with loss of postural tone. So this is the just a simplified tree. So it is if the patient has disequilibrium, which is the most common, is either uncompensated vestibular disorder, benign positional vertigo, multifactorial dizziness of elderly people, or neurological disorder. If it is vertigo, if it is recurrent attacks of vertigo, then most likely it is benign positional vertigo, migraine, or Meniere's disease. If it is a single attack and prolonged attack, it's vestibular neuritis, previously known as labyrinthitis, or can be posterior circulation stroke. Thank you. So some common facts and figures. As outpatient in primary care or in the subspecialty clinics, benign position of vertigo and vestibular neuritis are the most common diagnoses reached, with migraine coming after that. Uncommon other diagnoses like Meniere's disease, stroke, or cerebellobentine tumor are really rare. The figures are almost the same when it comes to emergency department attendance, and this is the diagnosis achieved by either neurologist or otolaryngologist. And again, benign paroxysmal position of vertigo and vestibular neuritis are the most commonly diagnosed conditions. So we'll move to syncope. So the diagnosis of syncope is coming from Greek, which means to interrupt. And syncope is a sudden, transient loss of consciousness with loss of postural tone due to inadequate cerebral blood flow. And it is usually followed by spontaneous recovery. And this loss of consciousness usually happens within like few seconds of the hypoperfusion. And I must stress here that to diagnose syncope, it has to be loss of consciousness, loss of postural tone, and spontaneous recovery. So this is just an algorithm from UpToDate. It's very nice. As basically, when you find a collapsed patient, it's either you have to make sure that are they conscious or not. If they are unconscious, you must make sure that are they still breathing and have pulse or not. If no, then you have to start your BLS or ACLS protocol, depends on the situation. And if they are unconscious but breathing and have pulse, you can categorize them as did they lose consciousness before the fall or after the fall. If it is before the fall, then most likely it is a syncope. If they lost consciousness after the fall, most likely it is the loss of consciousness is because of head trauma, because of the fall. So we should always consider syncope as a symptom and not a diagnosis. It is usually self-limiting, rapidly onset with variable symptoms. Sometimes can have like warning signs before it, sometimes not. And it should recover without any medical or surgical intervention. Just a quick note about syncope mimics, like alcohol intoxication, sleep disorders, seizures, psychogenic pseudosyncope, trauma or concussion, hypoglycemia, and hyperventilation. And now we'll discuss the causes of true syncope. So it's either, there are like four broad categories, like a neurally mediated, orthostatic, cardiac arrhythmia, or structural cardiopulmonary disease. And despite all that, there are like 1/3 of cases remain undiagnosed or unexplained. The incidence increases with age. Obviously, there isn't much difference between male and female, apart from the two extremes of the age, but it increases with age rapidly, especially after the 8th decade. So the impact of syncope: 40% of patients will experience syncope at least once in their lifetime, and it accounts for about up to 6% of hospital admissions and 1% of emergency room visits. 10% of elderly patients who have experienced a fall is due to syncope, and 6% of these syncopal attacks result in a major morbidity, include fractures or motor vehicle accidents. Minor injury is reported in 29% of patients. So the impact on the quality of life of syncopal attacks: anxiety and depression, altered daily activity, restricted driving, and change of employment. So it has a great impact on patients' quality of life. So what to do once the patient arrives? So you have to have a diagnostic objectives. First, to do distinguish true syncope from syncopal mimics, determine the presence of heart disease, because it is the most dangerous and the most cause that associated with mortality, and then to establish the cause of syncope with sufficient diagnostic certainty to assess the prognosis and initiate effective preventive measures. So initial evaluation. So if you have a suspected syncopal attack, you have to take a thorough history and a good physical examination and perform an ECG initially. This is the Class 1 recommendation by American Heart Association. Then after that, you have to reassess the underlying cause and treat accordingly. And so if you are in a family medicine clinic or in accident and emergency, obviously the question is where to send the patient. So if the patient has a serious medical condition, it is a Class 1 recommendation that the patient should be admitted for evaluation. If a serious medical condition excluded, then it is reasonable to manage it in either in observation area in accident emergency, or send a patient to a specialized outpatient clinic. However, if you think there is a cardiac etiology underlying, maybe you should admit the patient, because it's a Class B recommendation where the risk and benefit are equal. So diagnostic plan is, as mentioned earlier, you have to have a detailed history, thorough physical examination, ECG, which can detect like long QT, pre-excitation, conduction system defect. You have to do lying and standing blood pressure, cardiac imaging, echo, with including LV function, valve function, and exclude hypertrophic obstructive cardiomyopathy. Carotid sinus massage can be done, but preferably in an appropriate setting, and preferably during the tilt table test. So monitoring, including the Holter event monitor or insertable loop recorder, are also recommended to investigate unexplained syncope. Other diagnostic test is the head-up tilt table test, which include drug provocation if necessary and carotid sinus massage. Electrophysiological studies may help if epilepsy or seizure is the underlying cause. Neurological tests, including radiological testing, it's not really recommended and rarely positive. It can be useful only to assess the result of the syncope, including head injury. So the diagnostic yield, as you see, 40% of the cases are achieved by only history, physical examination, ECG, and carotid sinus massage. Tilt table tests can achieve a diagnosis 27% of the patient. The rest is less and less. So, like any condition, there are now many scores for syncope. I think there are 28 different scores to assess the risk of or the risk stratification of syncope. This is the Canadian one, which is the most most straightforward and it's easy to apply, and it has 11 criteria. If the patient meets all of these criteria, he has an 83% risk of death or major comorbidity, and as you have less and less risk factors, the risk reduces. So I'm just going to talk quickly about now some specific conditions. The cardiac arrhythmia like brady and tachycardia, long QT interval, torsade de Bois, Brugada syndrome, and drug-induced cardiac rhythm issues, structural cardiopulmonary abnormality, and neurally mediated the vasovagal and carotid sinus, and then the orthostatic hypotension. So with the cardiac syncope, this is why I in the beginning said it's very important to exclude the cardiac. You have a 6 months 10% mortality rate if you present with a syncope related to a heart disease. Overall, over the years, the risk of sudden death or sudden cardiac death is increased or doubled. And if you see the survival, so the non-cardiac and the asymptomatic, they're almost the same survival rate, whereas the cardiac and markedly reduced. Just a quick note about the structural cardiovascular disease, and basically it is either due to causing hypotension or pain-inducing neural reflex or neurally reflex bradycardia. So these conditions like acute myocardial infarction, which can cause either bradycardia or low output, hypertrophic cardiomyopathy causing reduced output due to obstruction, acute aortic dissection, pulmonary embolism, which is, it's not mentioned to be a very common cause, but it's like a conflicting opinions. Some people think it's very common, some people think it's not, it's less common. Valvular heart disease can also induce syncopal attacks, especially during exercise. Cardiac arrhythmias causing syncope is either bradyarrhythmias, things like sinus arrest or a AV block. It can be accompanied by vasovagal or carotid sinus syndrome, tachyarrhythmias, atrial fibrillation, paroxysmal SVT or VT, torsade de Bois, long QT interval. These are all can cause syncopal attacks. Neurally mediated reflex, things like vasovagal, carotid sinus, and situational syncope. For example, of situational post-micturition, cough reflex, swallowing, defecation, or blood drawing. And basically, this is the mechanism of all the neurally mediated, and basically it is all through stimulation of sympathetic and parasympathetic nervous system, causing vasodilation peripherally and bradycardia. Diagnosis of the vasovagal usually as with any condition, history and physical examination, ECG and blood pressure. You need to do a head-up tilt table test.
Sorry, doctor, you have 5 minutes.
Okay, right. So it is after a fast of 2 minutes, you need to do an ECG, continuous blood pressure monitoring, preferably through digital sensor, not a cuff. The endpoint is loss of consciousness. The general measures are in the acute, you need to teach the patient the physical maneuvers to counteract the reduced blood pressure. Long term, you need to train them to how to rise from bed slowly, and diet, fluid, salt intake, supportive stockings, drug therapy, and pacing at the end. Most of the medication we use in vasovagal are actually either class 2A or 2B. So there isn't a very good support for medication therapy apart from midodrine. A carotid sinus syndrome, and it is rare. It's less than 1% of the patient. Carotid sinus can explain recurrent or frequent falls in elderly people. There's the carotid sinus hypersensitivity, where there is a clinical or hypocardia, bradycardia, and hypotension with no symptom from the patient, and in this case you don't need to treat. There's a nice sort of a study showing that if you do basing, dual chamber basing for people with carotid sinus hypersensitivity and vasovagal, the rate of recurrence of the syncope reduces markedly. Orthostatic hypotension, it's either drug-induced, like diuretic vasodilator, primary autonomic failure with multisystematic Parkinson's disease. Secondary is an autonomic failure in diabetes and alcohol. Treatment strategy: hydration, fluid and salt intake, minimize alcohol and caffeine, sleeping with head elevated, supportive stocking, and drug therapy. Right. Well, what's special about Ramadan? Dehydration increases the orthostatic hypotension. There's also increased risk of ventricular arrhythmia, especially in patients with prolonged QT interval. Dehydration also aggravates intracranial hypotension. Hypoglycemia and neuroglycopenia can be interpreted as dizziness or syncope. There is a small increase in Ramadan of cases of central venous thrombosis, but it is a very small increase. There is no risk, there is no stroke risk increase, and no cardiovascular risk increase in controlled patients. So in conclusion, what to do with patient with syncope of cardiac arrhythmia? You need to do ECG, history and examination ECG, monitoring. Insertable loop recorders are a very good tool. Treat with medication and ablation and pacing. Of the structural heart disease, again, you may, the same as above, but you may need a surgical intervention. For neurally mediated, you need to do history examination, ECG, tilt table testing, plus cardiac monitoring. Treat patient with education, diet, exercise, pacing, and medication may help. Brain imaging and EEG are of very limited use. Thank you.